Let's talk about a controversial, thought-provoking concept, and that is curing periodontal disease. For so long we've talked about control, but now I think I can make a valid argument that we can cure disease. So the title of this short video is Yes, You Can Cure Your Periodontal Disease. And that really is addressed to the patient. Yes, patient, you can cure your periodontal disease. The first step is to have an understanding of the difference between an infection and inflammation. Infection is caused by an irritant, whereas inflammation is the body's response to an irritant. In summary, infection is the cause, whereas inflammation is the body's response. But inflammation is a double-edged sword. It is necessary for healing, but it also contributes to tissue destruction in periodontal disease. What are the inflammatory diseases? We talk about the systemic link between periodontal disease, cardiovascular disease, and diabetes mellitus. But also, we consider rheumatoid arthritis and now Alzheimer's disease as inflammatory diseases as well. Let's define chronic adult periodontitis. It is a bacterially induced chronic inflammatory disease. But what is periodontal health? And this is significant. Pay close attention, because this is a document that was issued by the American Academy of Periodontology in July of 2011, where they defined health. Health is characterized by the absence of inflammation, which may appear clinically as redness, suppuration, and bleeding on probing. Notice that the objectives of periodontal treatment are to reduce inflammation to a subclinical level where there's no bleeding on probing, there is no further attachment loss, and it's stable over a period of time. And the best way to treat periodontal disease is pocket elimination. Pocket elimination procedures include scaling and root planing and gingivectomy. That was what we were able to do in the 1950s. Then as we moved forward, we had flap and osseous. Now we have regenerative surgery. And then we have the dental laser has become popular in the last few years. And in no way am I saying that we should not do pocket elimination, but often we cannot eliminate the pockets. But does that mean that we still have disease, or do we simply have a periodontal defect? Can you have health without pocket elimination? Yes, I think you can, by converting a periodontal pocket into a periodontal defect. So let's define what is a periodontal pocket. Excessive probing depth, bleeding on probing, suppuration, progressive attachment loss, and malodor. And we're going to talk about malodor and the significance of that, which is a very important thing to the patient. By the same token, a periodontal defect exhibits excessive probing depth, no bleeding on probing, no suppuration, long-term stability over time, and no malodor. If we're going to deal with malodor, first of all, we've got to discuss the most effective, least expensive mouthwash. And this is the active ingredient in household bleach, which is sodium hypochlorite. And I would urge you to look at this video, which gives more in-depth exactly how this solution should be mixed, as well as a disclaimer which patients need to be aware of before using this. If you have a periodontal defect, yes, you have excessive probing depth. And how do you get this solution deeper within that defect to remove the biofilm? By the use of a dental water jet. And here's an older article which is still very significant. Moderate hydraulic forces produced by a dental water jet significantly remove the biofilm, and what we're talking about is the biofilm left within the residual periodontal defect. Following the use of that particular mouthwash, whether you use it as a mouthwash or whether you use it in the water irrigator, this needs to be followed by the cleaning or scraping of the tongue. And here is a link to that video giving you more in-depth information on that. Basically, 90% of the bacteria left in the mouth after brushing and flossing are on the posterior third of the tongue. And how can you have periodontal health when you've got significant bacteria that are not being removed? And the instrument that I like for removing this was designed by Dr. Robert Ripich, who was a mechanical engineer before he went to dental school. He designed many prototypes on this until he got the one that is rounded and bent and angled in such a way that you can get well back on the posterior third of the tongue. Often people say, well, I brush my tongue. Well, you only brush the anterior part of the tongue, number one. Number two, with a wet toothbrush, all you do is basically smear bacteria around. And using this tongue sweeper, as he refers to it, is really a misnomer. It is a scraper, and you need to vigorously get back and scrape that area. Here is Dr. Ripich's contact information. The tongue scrapers are made out of metal, will last a lifetime, and the basic cost of these are $7 each. And they have color-coded rings around them so that the family members can each have a separate one. Here are the steps to ideal home care, or as I refer to it, maximum reduction of bacteria. You need to brush, you need to do interdental cleansing, either with floss, interdental brushes, stimulants, and so forth. You need to rinse with the sodium hypochlorite solution that we mentioned earlier, but leave the residual in your mouth before you rinse. You need to scrape the tongue, especially the posterior third, with the tongue scraper with the residual sodium hypochlorite solution intact. This will do a great job of disinfecting the tongue and getting rid of those sulfur-forming bacteria which are so associated with malodor. And then you need to rinse with plain water because, as you'll note in the disclaimer that we mentioned earlier, in no way do you want to swallow any of the sodium hypochlorite. Why is smoking cessation so important? If you learn nothing else from this presentation, this is worth it. If two patients both have generalized periodontitis, the patient who smokes has a 247% greater chance of losing their teeth compared to the non-smoker. Ladies and gentlemen, when that information is shared with a patient, that is very impactful in encouraging them to stop. And then there's a short video on smoking cessation counseling on the web textbook. It's about 8 minutes long. It's a little bit corny, but it is very effective. I would recommend that you read that and implement that in your practice. The first step to motivating the patient is to score the patient using the MMPPI. And there are several links on the web textbook that go into detail on that. Why is the use of the MMPPI so important in motivating the patients? First of all, this has sound scientific basis. It is evidence-based, statistically validated, it's accurate. It has been published in the Journal of Periodontology in February 2014, and very importantly, in 2015, it received the Clinical Research Award from the Academy. How do you apply this in clinical practice? And this is what you really want to know. And to get very much in-depth information, go to the video, part 2 on clinical application in the web textbook. The objectives of a clinical application are as follows: to motivate the patient to accept and complete treatment, because the more motivated the patient is, more patients will accept treatment and complete treatment. Second, you need to simplify the scoring as we have done so that it requires no chair time from the dentist. The scoring can be done by dental hygienists and assistants, and they need to be trained to do that. Fourth, you need to create patient referrals by giving the score sheet or blank score sheets to the patients to take home and share with family and friends, and we have found that this really does create or generate patient referrals. The keys to success: And what I want you to notice on these, all the keys to success are the patient's responsibility. They have the responsibility to brush and clean interdentally all these surfaces effective on a daily basis. They have to clean the posterior third of the tongue by scraping it with a residual sodium hypochlorite solution. They need to complete the recommended treatment, including the options that we listed earlier on pocket elimination. They need to adhere to the recommended maintenance appointment. They need to control their blood sugar if they're diabetic, and they need to stop smoking. All of these are under the control of the patient. None of them are under the control of the dentist. Now here's the score sheet. And this score sheet can be found and downloaded and printed if you would like. And it's found in the resource section of the web textbook. It's in there in Japanese. It will be put in there in French, Spanish, Italian, Portuguese perhaps, as well as English. And in the lower right, we have the keys to success to constantly remind the patient what they need to do and what is their responsibility if we want to have this level of success. Now let's look at a little science that we did in our statistics in the original study. We used the Cox proportional hazard model so that we could have a score even on those teeth that did not survive. And the higher the number it is, it's more significant. And you will notice in red that smoking was the most significant factor, well above anything else. But you will notice in aqua or blue that age, furcation involvement, and molar type were the least impactful things. So what this study does, it provides two key points. First of all, it shows how significant smoking is on prognosis, and it also shows that furcation involvement is not nearly as significant as we have all been told and believe. Is the patient guaranteed the level of success? We've basically answered that question because I said this is not a promise of success, but guidelines that allows the patient to be successful and cure their disease. Second, the patient assumes 100% of the responsibility for success, as we have pointed out over and over in the keys to success. The dentist assumes no responsibility for the outcome. It's all up to the patient. Let's talk about some practical considerations. It markedly motivates the patient to accept treatment when they're told they have an 87 or a 93 or a 95% chance of keeping their teeth for 15 to 30 years in health. It is fast, simple, and easy to score, and we've worked on that hard over the last few years so that dental assistants and hygienists can do the scoring. Third, it increases referrals from patients or self-referred patients, because you should give the score sheet filled out to the patient and ask them to share this with family and friends, and you will find that you will get new patients from that. Fourth, it proves that many teeth that were initially thought to be hopeless are in fact treatable. And finally, it proves that teeth with furcation involvement can have a good long-term prognosis. So the conclusion is, if you control the bacteria and you minimize inflammation, then you can cure periodontal disease.